I'm Dr. Kravitz, and this is a complex cataract extraction in Nanophthalmos with a prophylactic iridozonulohyaloidectomy. This is a patient with Nanophthalmos and an axial length of about 19.7 millimeters, a shallow anterior chamber, as well as chronic angle closure glaucoma. Paracenteses are made, followed by injection of viscoelastic. The main wound is then made. Next, a psychodialysis spatula is used to break the posterior synechii. Following this, 4 iris hooks are inserted into the eye in a diamond configuration, with 1 hook inserted subincisionally. I find that this subincisional hook is very helpful to keep the iris away from the phacoprobe during cataract extraction. A cystotome is used to puncture the anterior capsule, and a continuous capsulorhexis is then performed. Cataract extraction then proceeds normally. It is often helpful to first debulk the nucleus to create more space in these cases. Before coming out of the eye, I inject viscoelastic to keep the anterior chamber formed, as shallowing of the anterior chamber can lead to aqueous misdirection or suprachoroidal hemorrhage. I inject the intraocular lens into the capsular bag without difficulty and remove the iris hooks. Next, I'm using myostat to constrict the pupil, painting the iris to ensure adequate effect as there is still viscoelastic inside the eye. And then I'm closing the main wound with a 10-0 nylon suture to maintain anterior chamber stability during the next step of the surgery. I'm now performing the iridozonulohyaloidectomy using the anterior vitrector. I'm engaging the peripheral iris with the port down on IA cut mode with a low cut rate to first perform a surgical iridectomy. I then advance the probe about 2 millimeters posteriorly to cut the peripheral zonules and anterior vitreous and create a unicameral eye. This will reduce the risk of aqueous misdirection postoperatively. I then remove the viscoelastic and hydrate my incisions. Thank you for watching.